Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. Today, we are going to cover two most commonly tested topics in NAC OSCE. One of them is going to be the neck physical examination. And the second one, which is very, very commonly tested, even more than neck examination, is the shoulder. So we're going to start with the neck physical examination, and then we are going to do the shoulder. So for the neck physical examination, this is going to be, might be in the licensing exam, but remember, with the neck, you have to be very careful. It's a very, very sensitive area. Before touching the patient or before doing any special test, please have a proper eye contact with the examiner and tell the examiner that I'm going to perform this special test. 90% of the time, the examiner will tell you, just explain the examination, do not perform it. Why? Because it is going to hurt the patient. It is very bothersome for the standardized patient. As long as you know how to do it and you can explain it, you should be good. Okay? If the examiner says go ahead, then perform it. But again, remember, the patient is not a real patient. That's a standardized patient. Be gentle. Act. Don't apply pressure. Okay? It's neck, very sensitive, very vital place to apply pressure. So you don't want your patient to end up paralyzed. Okay? Please be careful. The test that we are going to cover is the Sperling test, El-Hermet test, and also Hoffman test. There are so many special tests that you need to perform for neck physical examination, but out of all of them, we are going to perform these three because these three is going to be asked in the licensing exam. The rest of them are, like they need expert to perform it, and they're not going to ask you. As long as you mention these three, you are good. Okay, you don't have to worry. All right, so these are the special tests. Now, how to structure the NAC OSCE neck examination. A systematic approach score better than isolated maneuvers. So it means if you apply this station in a very structured way, you always secure more mark than somebody who is more knowledgeable, but he is just approaching the station very haphazardly or disorganized. Introduce yourself, confirm the patient name and ID, explain the examination, explain your rule, obtain consent, and offer analgesic, and chaperone when appropriate, which I doubted that they're going to provide you with one. Begin with the inspection. We always start with general inspection. With the general inspection, what do you see? My patient is sitting on the edge of the bed in a comfortable, the patient looks comfortable, not under any kind of stress or distress. The patient is not, for example, using any sort of mobility aid. I do not appreciate any abnormality on her limbs or shoulder or neck. And in general, the patient looks fine and the patient is conscious, and then move on. So posture, head position, asymmetry, muscle wasting deformity, skin changes, and whether the patient is guarding the neck. So these are, one is the general inspection. Then for the focused inspection, one more thing before we go to focus inspection. For the general inspection, you need to inspect the patient from the front, from the side, and from the back. So this is commonly mistaken by IMGs. It's a common mistake, but it might cost you a little bit when you're performing it in the station. So in order to get 5 out of 5, it is your job to go around, not the patients to move around for you. Why? Because we always say, I will try my best to keep you as comfortable as possible, right? So if I ask my patient to turn left, turn right, turn around, so obviously he's not comfortable with that. If I am someone that I can move around, I can do that so my patient is comfortable. So from the front, I do not appreciate any abnormality, right? At the side, everything looks normal. The cervical lordosis, normal. I do not appreciate any abnormality from the other side, from the back. And then the contour looks normal, right? So then you're done with the gender. Then you go for the focal or focused inspection. For the focused inspection, we cover seeds, swelling, erythema, edema, atrophy, asymmetry, deformity, and scar, skin change, surgery, sign, and so on and so forth. Palpate. Then, before you palpate, you check for the temperature. Now, I would like to touch your neck, if that's okay with you. And then with the back of your fingers, you start touching both sides of the spine and report if there is any temperature changes. Then move on to the palpation. Palpation, always we are going to go from the base of the occiput. So the one that you can palpate is the second cervical vertebra. And then all the way you go down to the 7th cervical vertebra. The one that's prominent, when you touch your back of neck, the one that's prominent, you can see it, right? That is the 7th. That is the 7th cervical, right? And the way you can tell is when you ask the patient to bend his neck forward. If this moves, this is 7 because T1 is not moving, right? So you can just palpate all the way from the spinous process all the way to T1, and then the paraspinal. The trapezius, why we do palpate it? Because most of the neck pain comes from the stiffness of the paraspinal muscle and also the trapezius. So we check that area of the focal tenderness or spasm. Assess active range of motion. Flexion. Ask the patient to copy me. Do this. Or touch your chest with a chin. Like this. Then try to look up as much as possible. Then can you touch with your ears on your shoulder? Or copy me. Whichever is easy for you. And then ask the patient to turn around on your left side and on your right side. So the patient should be able to turn 80 degrees each side. And then you report. Forward flexion is normal. Backward extension is normal. Lateral side flexion is normal. Rotation to either side is normal. So not only do it, report it. Then complete the focused neurological screening for the upper limb. Obviously, I will show you how to do it. So we start checking for the motor, and then we go for the sensation, and then we are going to go for the reflexes. All right, so red flag, radicular pain, paresthesia, dermatomal sensory loss, or reflexes. If there is any changes like this, it suggests the cervical nerve root involvement or cervical radiculopathy. Paresthesia, if there is sensory loss, if there is any issue with the reflexes, think about cervical radiculopathy. Hand clumsiness, gait disturbance, bilateral symptoms, hyperreflexia, right? Hyperreflexia, upper motor neuron. Signs suggest cervical myelopathy. Trauma, fever, malignancy, history of severe night pain, unexplained weight loss, or progressive neurological deficit requires urgent escalation. Do not force painful maneuver when serious instability or cord compression is suspected. Good. That's why I made it red. That is something that you have to avoid. Now for an inspection, I think I did mention, cover the seat, for palpation, I did mention it. For the range of motion, mentioned it. For the neurological, we cover. For the neurological examination, I will perform or I will cover the motor, sensory, and reflexes. Then start with motor, follow with the sensory, and then finish it with the reflex. Special tests, use them only after the basic. We usually do it at the end, but remember, if you're running out of time, do the special first, the special test before neurological examination, because for the neurological examination, for the total motor, sensory, and reflex, you might get 5 out of 5, but for a special test, for each one of them, you will get 5 out of 5. So if you miss 3 special tests, you miss or you lose 15 mark. So it is, again, comes back to the time management. If you know that you can manage your time, always do it at the end. That's why it's called special. But if it is something that you know that you have time, you have to do it right now, but you might run out of time at the end and you don't want to take the risk, do it before neurological examination. Exam tip, local neck pain alone is less specific. The higher scoring clue is whether the test produces radicular arm symptoms or myelopathic feature. Special test number 1, Sperling test. So this is how you do it. I'm not going to go one by one on each of them because I'm going to explain it in the picture. So if it is positive, reproduction of the pain on radiating or radiating pain into the ipsilateral arm in the radicular pattern, less specific. Okay, so very short OSCE wording. This is the most important part of this slide. I would extend and rotate. So when you're performing, you need to stand behind the patient and ask the patient to extend his neck and then rotate it. Extend, rotate, tilt. Extend, rotate, tilt. Then you apply pressure downward. And if the pain on the side that the patient is tilting his head, if it shoots down the arm, it means the radiculopathy is positive. Sorry?
Where to apply the pressure?
Head, top of the head. Yeah. I show you the picture, yeah. Here.
Oh.
So this is how you do it. You ask the patient to extend the knee, rotate, tilt, and then apply pressure. Again, when you're performing here, again, even here, please just act, don't even touch. Because it's very, very uncomfortable for the patient who is going through this physical examination for no reason. Neck extension, head rotated toward the affected shoulder, axial load placed on the spine, reproduction of the pains at the patient's shoulder, arm pain, indicate the possible nerve root compression. Again, before we do it, we just turn around, have a proper eye contact with the examiner. That now I would like to perform a special test that's called a Sperling test. Wait for the permission. They might say skip it, or they might say explain, do not perform. Then you will say that I will stand behind my patient. I will ask my patient to extend his neck, rotate to the affected side and tilt it a little bit. And then I will apply pressure on top of the patient's head downward. And if you can say this, then you're good. They're not going to ask you to perform because it's going to cause a lot of pain and discomfort for the patient. At the end. No problem. So a special test 2 and 3, Ehlers-Danlos sign and Hoffman sign. So ask the patient to sit comfortably. So again, it's better to show you in the picture rather than explain it one by one. So let's go to the OSCE first. If the Helmer or Hoffman is positive, mention consent for the myelopathy and the need for the fuller neurological exam and urgent escalation when clinically appropriate. So how do we do the exam for the Ehlers-Danlos test, which is also called the sign that's creating or the sign that's gonna produce this test is called L-Hermit sign. So L-Hermit sign is when you ask the patient if the patient has cervical myelopathy, you ask the patient to sit and just look down or bend his head forward. This will produce a shocking, like electrical shock pain that radiates down the arm and also back and even in legs. Even in legs. Okay, so this is positive for cervical myelopathy. How to do that? So if the patient does not have pain on his own while he is bending his neck, then we will apply pressure. Okay, so it's done in 2 steps. First, we ask the patient to sit down and then bend his neck forward, see if the patient has any radiating pain that's radiating or shooting down the arm, back, and even legs. If the patient says yes, it is positive, you don't have to do any other test. If the patient says no, I don't feel anything, then we apply. Then we apply pressure downward, and then the patient may have pain. Good? So very short OSCE warning. I would ask the patient, again, before we do it, we will turn around, have a proper eye contact with the examiner, and say that I would like to perform the second special test, which is called L-Hermit test, to rule out cervical myelopathy. And the examiner would say perform, or would say explain, do not perform. Then he would say, I would ask the patient to flex his neck and see if there is an electrical shock sensation shooting down the arm, spine, and leg. If it is positive, it means the patient has cervical myelopathy. If negative, then I will apply pressure on top of his head to see if it is positive. But mention that I do it gently. Now, for the Hoffman's test, you ask the patient to relax his hand. You get the middle finger. You get the middle finger like this, and you flick it. So when you flick, if the patient has cervical myelopathy, this index, the index and thumb will meet. They will go this way. Look, if I have a cervical myelopathy, if I do this, this two goes together. They meet each other. If it is negative, this is negative, right? See, I flick the middle finger and nothing happens. Why? Because I don't have cervical myelopathy. Let's say if I have cervical myelopathy, when I do this, they meet. Good. So this is how it's done. So again, I would like to perform Hoffman's test. This is not very serious. They will ask you to do it. Obviously, you're gonna ask the patient to relax and rest your arm. I'm gonna flick on the middle finger. Is that okay? And the patient say yes, and to flick. If the patient does this, you would say the Hoffman test is positive. Now, how to score well in the station? What examiner usually reward and common pitfall to avoid? So now the things that secure us a lot of mark and the things that we should avoid to not to lose mark. So use consistent exam sequence, inspect, palpate, range of motion, neurological screening, then special test. Again, if you're running out of time, switch the special test with neurological. Do the special test first, then at the end, do the neurological examination. So before, as I mentioned so many times in the lecture, before I start, I will let the examiner know my structure. Like for this physical examination, I'm talking directly to the examiner. For this physical examination station, I would like to start my physical examination, or my physical examination consists of 4 parts: an inspection, palpation, a special test, and then I will end my station with a neurological examination and summary. So even if I run out of time, the examiner knows that I know how to approach the station. And then instead of giving me 0 for the neurological examination that I didn't have time to do it, he will give me 2. Not 5, but 2. not 5, 1. It's always better than 0. Because I mentioned that I will do it, but I didn't get the chance to do it. Right? So at least he knows how I'm approaching. I'm very structured. I know things, but I couldn't beat the time. And I will pay for it. 3 mark is a lot of mark. I pay for it. But I mentioned that I do it, and the examiner will give you 2. Link the positive findings to likely clinical meaning. Radiculopathy for a Sperling, possible myelopathy for the Elhermet or Hoffman. State what you would do next if you find red flags. Full neurological examination, gait assessment, and urgent senior review or imaging when indicated. So things that we have to avoid doing it. Doing a special test before basic inspection, range of motion, neurological examination. We never do special tests at the beginning. We always do it at the end. Unless we have 1 minute or 2 minutes, then we have no choice to cover the special test. Because I will fail this station if I don't do the special test, regardless, right? So I will cover the special test. Not at the beginning, but before neurological examination, if I know that I'm running out. Calling local neck pain alone a positive Sperling test, which is wrong, right? Using excessive force and worsening pain unnecessarily. See, excessive force. We never apply any pressure. We just act that we are applying pressure. Forgetting that the myelopathic clues are more urgent than isolated mechanical neck pain. Failing to summarize findings clearly to examiner at the end. So, closing summary examples. The neck examination suggests mechanical pain, cervical radiculopathy, possible cervical myelopathy. I would correlate with the neurological finding and escalate urgently if there are core signs or progressive deficit. And that's it. You're done with that station.